function, COPD with gold guidelines, and and then the expert panel report for asthma. So we're going to talk about with pulmonary function test that it's good to differentiate with these PFTs for restrictive versus obstructive disorders. Also classifying disorders, asking if there's reversibility, lung volumes and capacities, bedside spirometry, DLCO, COPD, and asthma. So you guys, when you guys are given somebody's personal best or predicted values, of course, it's mainly predicted on the patient's height. Now, don't worry about you guys having to memorize predicted. As I said before in class, there's no way you could, because it has all these different predictors that go into it. So in order for the machine to calculate the percent of predicted, or if you're asked to do that, if you guys can remember, you're just looking at the measured value of what the patient actually performed over their predicted value. For an example, if your patient was able to perform on say a forced vital capacity of 4 liters and the predicted was 5 liters, you just go measured over predicted. So 4 liters over 5, and that's 80%. Standard equipment, both the body plasmography and then just a bedside or a small handheld spirometry. So there will be a few ways in which you'll be asked about the lung volumes and the capacities. So remember that the 4 volumes are your residual volume at the very bottom, your expiratory reserve volume, your tidal volume, and your inspiratory reserve volume. The 3 volumes, IRV, tidal volume, and ERV, make up your vital capacity. Your inspiratory reserve and tidal volume make up your inspiratory capacity, and then your 2 expiratory volumes, ERV and RV, make up your functional residual capacity, and all those make up total lung capacity. So if you guys can remember the mnemonic, I believe Sputable Bob from Kettering shared this one with me, but if you kind of look here, Irv and Irv took their TV in the RV to go camping. They took their RV on vacation, and in their RV, they took ice and fried chicken. And Irv and Irv are your loving couple, or the loving couple. So the loving couple, Irv and Irv, took their RV on vacation. With it, they took them their TV, and they ate ice cream or took ice, and fried chicken. If that helps you, great. If it doesn't, forget that I even said anything. Okay, I did put a video on here. It's pretty short. This is one of a student before performing a pulmonary function test through a body plasmograph, through the body plasmograph or the body box. So when you're looking at performing lung volumes and capacities, the body box or body plasmography is the preferred method as compared to your helium dilution or your nitrogen washout. It just tends to be a lot more accurate. Okay, in restrictive components, some characteristics, restrictive versus obstructive. In restrictive disease processes such as your ILDs, a pneumothorax, ARDS, you're looking at volumes that are measured to be lower. So your IRV, ERV, residual volume, total lung capacity, and then I meant to say your FRC are all lower. Whereas in an obstructive component, your flows are decreased. So your FEV1, your peak flow, your FEF, 25 to 75 and 200 to 1200, and then your ratio. So that's a big deal, is really looking at that ratio to tell you specifically. So once again, your obstructive disorders, here is a normal lung, and you can see that there's normal volumes depicted on this side, and over here when the lung becomes obstructed, the volumes get bigger. However, due to that dynamic compression Anytime you're doing a forced exhaled maneuver to measure the flow, it's significantly reduced. And then in your restrictive disease, here's normal depiction of lung size. And then in restrictive disease, your volumes will be a lot lower. Same thing as we talked about before, lung volumes and capacities. And just know that when you're needing to find a volume, say, take for example, if you're looking for total lung capacity, you're adding up the different volumes. Okay, so all 4 volumes together will equal your total lung capacity. Your IRV, tidal volume, and ERV equals your vital capacity. And then, as like we said before, IRV and total volume of your inspiratory capacity, ERV and RV are your functional residual capacity. So if you're given different volumes, you're adding those up to get a larger capacity. So it's 2 or more volumes that make up a lung capacity. And here's just another way to look at this. So maximum emptying. So we can forcefully get down to our ERV, but we can't ever get down in our residual volume. If we did, our lungs would be completely collapsed. And then when we take a big breath in, we can get all the way up into IRV, or inspiratory reserve volume. Okay, so tests we're going to look at are spiros, lung volumes, diffusion capacity, and bronchoprovocation. So lung volumes, TLC, or your total lung capacity, remember it's measured 3 ways: your body plasmography, or your body box, which is your preferred method. You have the open circuit nitrogen washout method, or the closed system helium dilution method. And we're not going to go into all of the specifics on these, but just when you, we'll talk about them again here, but when you think of your body box, it is more accurate, but it has to be, you have to have a center that can actually, keep up on it and want to afford it. So there would have to be quite a bit of volume to go in, patient volume, to actually be able to afford a body box. The other 2 are not as accurate. They don't give you precise measurements, but they can be a little bit easier and more affordable to add to a pulmonary department. So once again, your total lung capacity, we're looking at your vital capacity, which all of those volumes are measured via spirometry. And then your residual volume, you cannot measure via spirometry, but you can measure via body box, helium dilution, or nitrogen washout methods. Residual volume, once again, it cannot be obtained from spirometry. You can get that by subtracting your total lung capacity minus your vital capacity. It will be reduced in restrictive disorders and significantly increased in obstructive disorders based on the severity of the obstruction. So it should be about 25% of the total lung capacity, or about 33% of the vital capacity. Another way of looking at that is RV plus ERV is your functional residual capacity. So residual volume is the air left in the lungs after full expiration, and it's hard to measure. So you have to have one of these methods to measure it. Functional residual capacity. It's the resting volume in the lungs following a tidal volume. It is the balance between the expanding chest wall forces and the contractile rebound forces of the lung tissue. So hyperinflation protocols and CPAP-PEEP will increase your functional residual capacity. So the goal of those is to increase the functional residual capacity, leading to better gas exchange. In emphysema, your functional residual capacity will be increased. In pneumothorax or restrictive diseases, once again, that capacity will be decreased. So just looking at the principle behind a body box, the patient will sit in the closed box like we saw Liliana in the video doing. The patient pants with the closed glottis against the closed shutter. So the shutter is in the body box, and the patient will literally just kind of breathe against that closed mouthpiece. And then it'll incorporate Boyle's law to calculate volume 2. Okay, so it'll look at V1 over V2 is P2 over P1. So we're just looking at volume and pressure. So in general, you'll be finding the second volume. Spirometry, it's the most commonly performed pulmonary function test with both spirometry as well as lung volumes and capacities. If you're thinking about when you're doing your clinical simulation exam, if a patient is coming in with an acute exacerbation and if they're exhibiting respiratory distress, just remember that that will not be a good time to measure spirometry. So patients need to be, they need to be ambulatory. They need to be able to breathe comfortably in order for these to be performed. So if you're thinking about this, it's, you know, to measure disease like progress and treatment and management, but it's not going to be for a patient coming into the ED. So spirometry, the main maneuver that you have your patient do is the forced vital capacity. So the forced vital capacity, if that's less than 80%, it indicates that there's impairment with the lungs. So the forced vital capacity is used to assess the patient's ability to cough and deep breathe. Okay, so when the patient takes a big breath in, they're going to exhale. That's where this is going to start. So this initial portion is your peak expiratory flow, and then it'll continue on through, hopefully you get out to 6 seconds. You can get your patients to breathe out for 6 seconds, and that is indicated here on the X horizontal line right here. And then they'll take another inhalation afterward. So if you're looking at of the flow volume loop, if you look at the first 1 second, which would be about right, it would be around right here. This portion would be the FEV1. This first 1 second. Okay, so just an example question that you could see from MBRC is, what is the amount of air that can be maximally exhaled from a maximal inspiration? So, and of course, that would be your vital capacity. So the FEV1, I can't stress how important the FEV1 is for tracking disease. It is the maximum volume that is blown out in 1 second of the flow volume loop. It is the best indicator of obstructive disease. It's the best indicator of a reversible airway obstruction in response to inhaled bronchodilators. It's also very important when it's measured relative to the forced vital capacity, so that ratio. Less than 80% of the FEV1 indicates that there is impairment, and then less than 70% for the FEV1 FVC ratio means there's impairment. Other portions of the forced vital capacity is the peak expiratory flow rate. It's the maximum flow rate achieved by the patient during the FVC maneuver. It can also kind of show effort. So if that peak flow is good within 80%, then you can know that a patient gave a good effort with the PFT. It's also measured by portable device using patient's personal best. So just a little handheld peak flow is really good for asthmatic patients. And then you can measure their different zone levels. So this is green zone, which means it's all good, is 80 to 100% of the patient's personal best. 50 to 80% is the yellow zone, and that's once again of the patient's personal best. And then the red zone is when they can only obtain 50% of the peak flow, the portable peak flow. So you may on NBRC, excuse me, have to calculate a patient's different zones. So you may say, well, where does the green zone or yellow zone begin? So if their personal best is 600, then you would know that around 480 is the beginning and 300 is the cutoff between the red and the yellow zone. So maximum voluntary ventilation, I doubt you guys have seen this unless when you did go shadow in the pulmonary function lab, you may or may not have seen this, but It's to test the patient's muscle strength. It is a popular preoperative tool, a lot of times maybe for a neuromuscular disorder or when they think that the patient won't come out of surgery as easily. What it does is it has the patient just on a spirometry breathe as rapidly and deeply as possible for 1 minute. Now that would make somebody pass out if they did it for a full minute. So you could do 15 seconds and multiply by 4, or 12 seconds and multiply by 5 to get that 1 minute response. And then that'll look at the total volume measured. Normal should be about 170 liters per minute. And you might say, wow, that's a lot. Well, it is, because that's the maximum voluntary ventilation. So meaning that's you're breathing as hard and deep and fast as you can. So if you think about it, like normal minute ventilation is about 4 liters per minute. So this is significantly more than that. Okay, so back to the flow volume loop. Once again, we have the expiratory portion up here and the inspiratory portion on the bottom half of the curve. Okay, so of course, looking at the different shapes will tell you a lot about the patient's condition. So we have here a patient that they initially took that big blast and they had a good initial response, but if you look, then it became really concave or scooped out pattern. And then it took them a long time, or it took them a lot longer to get that air out, because once again, when they have an obstructive disorder, it gets trapped in there when they try to exhale it out. So you'll see that, there's a good response at the beginning, but it still takes them a lot longer to get that out as compared to this patient who took a deep breath and exhaled hard, and this patient was able to get it out. But this patient is also, as compared to the shape of this one, as you can see with this patient, it's more narrow and pushed in, okay? And that's indicating a restrictive component, okay? So a lot of times, the more restricted, the more thin this will be. And that's because they can't get that breath in, so they're not getting a good volume. They're able to get out what they did take in, but it's an impairment of taking the breath in. So normal spirometry. Now, one thing to note that when we talk about NBRC or ATS standards, American Thoracic Society, and the European Society also, they look at 80% of the FVC and the FEV1 as being normal. And then that ratio, the FEV1, FVC, is 70% for adults. But in younger kids, the ratio can be, it normally will be a lot higher. Okay, so you'll want to memorize it for COPD, but just know the younger the normal value goes up. Okay, so here we have more of a concave shape with asthma, so therefore their FEV1 percentage, the FEV1 over FVC, will be decreased. Okay, and then we're going to continue to say this over and over, but a 12% change in the FEV1 after a bronchodilator therapy means that they are reversible. I mean, they actually do respond to bronchodilators. So it says, what are other flow patterns to look for? So restricted, once again, it's smaller and more, it'll be smaller, thinner, and then it even, as it gets more severe, there'll be even less fluctuation in the top as well. So it'll be thin and small, which just mimics their lung volumes. Other ones to look for, vocal cord dysfunction. They're able to exhale okay, and then when they try to take a breath in, their vocal cords collapse. So it might look something like this. Both of these are indicating airway obstruction. So here it's more of the fixed large airway. So glottic or tracheal stenosis, tracheomalacia, vocal cord paralysis, foreign body masses. It'll just look like a little O And then it's very similar, so like a lesion or a mass for intrathoracic airway obstruction. So both of these would indicate airway obstruction. But without, these both might have normal values for the FVC, the FEV1, and perhaps the ratio as well. So you have to kind of look at that, and that's how the patterns will come in and help out. So once again, in an obstructive disease, the flow volume loop will be shifted towards left due to air trapping and hyperinflation. The decreased flow shows up in the top portion as a scooped out appearance. And then in a restrictive disorder, a smaller loop will be seen, and it could even be shifted more towards the right. So once again, other things to look for, make sure before you do a spirometry that you withhold the patient's medications before. So take, for example, albuterol, you should recommend holding for 4 hours. If it's a LABA, long-acting, about 12 hours. A SAMA, like ipratropium bromide, 4 hours. And then tiotropium LAMA, about 24 hours. And if it's inhaled steroids, just continue. That shouldn't affect it. But once again, we need to have that 12% change after bronchodilator therapy, and that would equal reversibility of an obstructive disorder. And then quality control, ATS standards does show here, looking at volume, leak time, what you might look for as far as QCing your spirometry and your pulmonary function machine. So they should all be done, both of them, volume and leak should be done daily. And then the time and the volume linearity will be quarterly, flow linearity weekly, and then software, anytime a new version comes out, it needs to be updated. So to look at volume, standard is a 3-liter syringe. Leak, 3 centimeters pressure for 1 minute. And then looking at the other flow and time with the other ranges that's here. But, just make sure that you do look over these because you might get there's about 3 QC. Some of them are on blood gases and some of them are on spirometers. To say that a pulmonary function test is repeatable, we have a difference between the largest and next largest forced vital capacity of 0.150 liters or less, okay? So the difference between the largest and next largest FEV1 is that 0.15 liters or less. Okay, sorry, just a second. Okay, oh, sorry. And then one other thing, no more than 8 maneuvers should be attempted. So which of the following should be used preoperatively to assess a patient's risk for respiratory complication following abdominal surgery? So if you look at these, the first one is maximum inspiratory pressure. That's muscle strength, spirometry, a CBC, a complete blood count, or ABG analysis. So the answer here is going to be spirometry. So looking at the patient's functional status of the lung will help predict how their outcomes are going to be after surgery. Another one you guys will see is the DLCO, and it's the diffusing capacity, measures the ability of gases to diffuse across the alveolar capillary membrane. The most common causes of reduced DLCO are emphysema and pulmonary fibrosis. So if carbon monoxide is a diffusion limited, but not a perfusion limited gas, it is affected by the membrane and not the blood flow. Normal is 25 mils per minute per millimeter of mercury. Normal is greater than 80% of predicted. And once again, it can be decreased in fibrosis and emphysema and increased in polycythemia. You can measure airway resistance using the body box. Normal is about 0.5 to 3 centimeters per liter per second, or at a flow of 0.5 liters per second or 500 milliliters per second. Another common challenge you guys might see is the bronchial challenge test. And it is a method of detecting hyperreaction in the airways. using a safe environment in the pulmonary function lab. You can use methacholine, mannitol, or exercise. And a 20% reduction in the FEV1 is indicative of RAD or at its max dose, or it's fine, a max dose of the either the methacholine or the mannitol or at exercise. So you can then, once they get down there at a specified dose to that decrease in 20%, then you can say, okay, they are hyperreactive based on this, and then the patient will end up getting a bronchodilator and bringing them out of their reactivity. So it's a good way to look at and see if asthmatics, kind of helping diagnose asthmatics and seeing how responsive they are. Exercise testing can come up. So indications, it'd be indicated to look at coronary artery disease, cardiac versus pulmonary disease, evaluate exercise capacity, looking at response to treatment, looking for exercise-induced bronchospasm, disability evaluations for work, and then looking at hypoxemia or desaturating with exercise to see, patients' exercise capacity. It is, of course, contraindicated in many patients when they have an acute instability of disease, so it definitely wouldn't be recommended at any of these contraindication lists. This is just looking at different values, so the VO2 max, anaerobic thresholds, heart rate max, breathing reservoir, and SpO2 with different disorders, and looking what the results would be. Something you'll get quite a bit on MBRC, both in the ClinSim and in the therapist multiple choice, is looking at oxygen titration with exercise, and it just assesses the adequacy of the arterial oxygenation in patients who are clinically suspected of desaturation. It determines the optimal amount of supplemental oxygen to treat their desaturation during exertion. So this is kind of a complicated picture, but it just looks at, you're going to assess the patient. If there's contraindications for exercising, then of course you're going to stop. If there's not, you're going to look at their baseline SaO2 or SATs, depending on what you have, what information you have available. If it's less than 85%, then you better stop. And then just continuing down. So you're just going and evaluating them with some sort of exercise, whether it be with walking or the bike, and then just seeing, titrating them down to the lowest possible oxygen level that keeps their SATs or their PaO2 or SaO2 where it needs to be within the range. Exhaled nitric oxide is to look at asthma. And what's nice about this, it's not considered the most accurate, but it is a non-invasive way. So it is used frequently, but as I said, if you look at EPR guidelines, it's not part of that, but it might come up on your test. So it's just looking at the fraction of exhaled nitric oxide. It's a non-invasive way to screen for asthma. High levels of it supports the diagnosis of asthma. Greater than 50 parts per billion in adults or greater than 35 parts per billion in children can indicate that there is asthma. Okay, let's see here. Okay, I'm going to stop 1 second. I think somebody maybe, let me go back here, and there we go. Okay, so I just had to admit somebody. Sorry about that. Let's keep going. Okay, so just for quick review, the pathophysiology of COPD, patients have airflow limitation and gas trapping. They have VQ mismatching from both increased dead space and as they get sicker, a decrease in their pulmonary vasculature. They do have mucus hypersecretion from just chronic airway irritation, whether that be from smoking or environmental factors, whatever they're irritated by. And then a lot of them end up getting pulmonary hypertension just from the consistent hypoxic vasoconstriction that happens in their pulmonary bed. So once again, spirometry is the only way to say that patients for sure have COPD. So you're looking at post-bronchodilator, okay? So patients are going to get their spirometry, and then they can take their inhaler of a bronchodilator, and then you're looking at those post-bronchodilator results. So the bronchodilator protocol would just be a short-acting beta agonist, or a short-acting anticholinergic such as Atrovent or Combivent, the two of those combined, and then measuring again 10 to 15 minutes after a short-acting is administered. So here is the performance exactly according. This is all according to GOLD guidelines. And then how you can classify GOLD is, first of all, the FEV1 over FVC ratio has to be less than 70%. Then you move on and look at the FEV1. So FEV1 mild is greater than 80% predicted. GOLD stage 2 or moderate would be an FEV1 of 50 to 80%. Severe would be a 30 to 50%. And then very severe would be an FEV1 less than 30%. My guess is, according to the practice SAEs that are coming in, you guys are going to be asked, you're going to get these PFT results, and you are going to be asked to classify GOLD guide COPD. Okay, so you're going to look at the FEV1 FVC ratio less than 70%, and then memorizing these FEV1s will tell you if it's mild, moderate, severe, or very severe. So looking at symptoms, so if you're looking to gather information with COPD patients, you can look at dyspnea. And the most common scale is the Modified Medical Research Council, and I have a picture of that next. Looking at their cough characteristics, looking at sputum production, wheezing, and chest tightness, and then this one came up quite a bit also. But evaluating pedal edema, because patients with COPD have comorbidities of cor pulmonale, which is the right heart failure, and pedal edema can be a really good symptom that they present with. So that'll really help. And then anxiety and depression as well. So here's an example of the Modified Medical Research Council's dyspnea scale. So it's a 0 to 4. 0, I only get breathless with strenuous exercise, all the way up to 4, I'm too breathless to leave the house, or I'm too breathless when dressing or undressing. So looking at that will really affect patients' quality of life. Other things to gather, once again, patients' exposures, whether that be to cigarette smoke or any environmental hazards that they might live with, their past medical history, looking at lung history and family's lung history, pattern of symptom development, history of exacerbations, presence of any comorbidities, the impact on the patient's daily life, the support that they have at home or in the community, and then smoking history or cessation. So are they still smoking, or have they quit? And then, of course, you providing good smoking cessation. Other things to look for are alpha-1 screening, chest x-ray to rule out co-infections, a CAT scan to rule out lung cancer, because lung cancer can go along with COPD, lung volume and diffusion capacity to characterize the severity, SpO2 and ABG to evaluate oxygen needs. If the SATs are lower than 92% or respiratory distress is present, then you can get an ABG. And then, but not if they're not showing those signs and symptoms. 6-minute walk test to assess their exercise tolerance and to see if they're needing O2. So management, of course, the first thing is smoking cessation, and there's a lot of evidence on that, but that's first. And then vaccines. So the influenza vaccine annually, And then there's two different types of pneumococcal. So the 23-valent pneumococcal is for COPD patients less than 65 years old and that have severe disease. And then the other one called the 13-valent pneumococcal, sometimes it's just like 23V or 13V, is a pneumococcal vaccine for all populations greater than 65 years old. Then stepping up with the management with pharmacology would be a SABA. So that would be your albuterol, just a short-acting beta agonist, and that would be for all patients PRN. And then a SAMA, which is a anticholinergic, that would be your ipratropium bromide. So you could also give them Combivent. You could give them Combivent or Duoneb, which is both of those. SABA and SAMA together. Then you start getting into your long-acting controllers. So your LAMA, your long-acting muscarinic antagonist, or your LABA, your long-acting beta agonist. Those are both going to help with controllers. Then inhaled corticosteroids are only given to patients with high eosinophil counts, and the reason why is because the problem with COPD is bronchoconstriction, not an inflammation. And so if they don't have those inflammatory markers, then it's really just going to add more medications. And when you give steroids, there's always a slight risk of increasing co-infections, just because steroids do reduce the immune response. Then you can look in your combination therapies. So your LAMAs, LABAs, LABAs ICS, LAMAs ICS, and then now and this year was the first time, and I don't think this will be on MVRC, is there's now a triple combination, which is a LAMA, LABA, and inhaled corticosteroid. However, they're seeing that it does help reduce exacerbations, but adding that steroid has shown to have some co-infections to go along with it. And then watch for and educate on correct use of inhalers and delivery devices. I sent you guys last week the medication update, and it had all of different medications and the delivery devices. Look over those just so you can familiarize yourself with some of the trade names for these drugs. And then the delivery devices, of course, they wanted to all get their share of the market. So they've added, each drug comes with its own specific delivery device, and that can be confusing. And we'll show you an example of how they might test you on that coming up. So bronchodilators and stable management of COPD, I'll let you guys read through this, but it's just showing that, regular use of both the short-acting and then the long-acting controllers really do help with symptom and exacerbation incidences. So here's the different groups. So when you're looking at groups A through D, this is showing that group A can just benefit from a bronchodilator, but as they show more symptoms, so this is exacerbation and more symptoms, then they start needing some controller meds. So either a long-acting LABA or a LAMA. Then C, a LAMA, which has been shown to be more effective at reducing exacerbations than a LABA. And an example of a LABA would be your Severity, and then a LAMA would be like your tiotropium. And then we have all of our combination therapies. And then if they have higher eosinophil counts, add in the inhaled corticosteroids. And then it's also really important that you do patient education. So they really do need to know when it is in the inhaled route, if it's a dry powder or an MDI, a pressurized MDI, or whatever the device, that they understand how to use it and have the dexterity to use it. Also, just for good patient care. And there's a lot of apps that can help this, that their insurance company, or if they have CMS, that they can, that their medication is covered. and they know where to get it. And a lot of the apps that are out there now, and it was on what I handed out last week also, you can look and see where the cheapest pharmacy is around for them. So really just taking the time to help them really will show better outcomes. Other management is pulmonary rehab, and then education. So smoking cessation, inhaler use, early recognition of their symptoms, nutrition support, managing anxiety and depression, and as well as introducing them to palliative care topics sooner rather than later, just so they and their families can get the support that they need. So continuing on with management, non-invasive positive pressure ventilation is indicated for hypercarbia, so high CO2, when that pH range is still above the 7.25, or when they're showing a respiratory rate greater than 30 breaths per minute with accessory muscle use. And then oxygen therapy for hypoxemia, especially with exercise. Long-term, they qualify for long-term oxygen when their PaO2 is less than 55 torr, and or their SpO2 is lower than 88% or lower. And as I said, make sure that you walk them as well, like a 6-minute walk test, because you don't want to just do it at rest and say, oh, they don't qualify. But then if they do start exercising, they may qualify for it. So other management principles of exacerbations would be FiO2 via nasal cannula or a Venturi mask. And remember that Venturi mask gives that precise FiO2. And then heated high flow nasal cannula is a good choice. And you can go up to 60 liters per minute with adults. And then once again, they have that specified FiO2. So when you're dealing with stable COPD or patient with having an COPD exacerbation, it is good to have a precise FiO2. Non-invasive if they can tolerate it, invasive ventilation, so intubate and initiate mechanical ventilation if need be. And then 3 other managements are continuing to up those bronchodilators, systemic steroids, and then antibiotics also if they need it in the hospital. So, yes, go ahead.
Quick question.
Sure.
Just going back to the GOLD guidelines real quick. I had a question, I believe, on the exit exam, asking which stage inhaled corticosteroids would be introduced. So would that be 3 or 4?
Let's go back. So in general, it's close. So over here, these are a little bit differently because they're looking more at symptoms and exacerbations. So that's why it's A, B, C, and D. So in general, ICS is now considered more last resort. Okay, not last resort, but for patients when they've tried other conditions. And so when they have a high eosinophil count is when they're recommending to do that. So I would say, I didn't exactly see it, but I would say closer to 4 is when they would, or if they have a documented eosinophil count. Any other questions for these, you guys? But that's really good example, Allison. You guys will, it'll come up a lot with these patients. Okay, asthma. It's an airway, the pathophysiology is airway inflammation from inflammatory cells, airway hyperresponsiveness due to irritants or antigens, and then airway obstruction due to bronchoconstriction. So once again, that bronchial challenge testing, so giving methacholine or mannitol, will measure the response of the airways to stimuli via spirometry, specifically looking at that FEV1 decrease. And then being able to classify the severity as intermittent means that the patient experiences symptoms about 2 days per week. Mild persistent says greater than 2 days per week, but not daily. Moderate persistent would mean that they experience symptoms daily. Severe persistent means that they, throughout the day, experience symptoms. Okay, here's once again looking at the asthma zones for management, and this is recommended from the expert panel report guidelines. And once again, peak flows 80 to 100%, no symptoms, able to do usual activities, usual medications that control asthma. So you can really educate your patients on what to do. Yellow zone means caution. Your peak flows anywhere between 50 and 80% of the personal best. Increase asthma symptoms such as shortness of breath, breathing faster, pale skin color. And it says call your physician if you are in the yellow zone. And then it also has them, what that means is your symptoms may indicate that you need an adjustment of medications, eliminate your triggers, stop any strenuous activities, and then add a reliever medication if they have that ordered. And then red zone, meaning medical alert, your peak flow is only half of what its personal best. Patients are very short of breath. They should take the reliever medication and call their doctor ASAP. And then just looking at asthma education through those guidelines, really that self-management to help these patients stay in their green zone. So self-monitoring to assess the level of asthma control and recognizing signs of worsening asthma, how to take medications correctly. So once again, do you take your quick relief medication versus your controller medications? And I was asked when I did a ClinSam on two different scenarios, they had patients taking their medications wrong. So take, for example, they would be, when they got short of breath, they would take a controller, and that's what they would tell you. And so you had to educate them on the difference between taking a quick relief and a controller medication. So this self-management's really important. And then developing a written asthma action plan which is what we saw right here. So when patients go home, they have this in writing and they know exactly what to do. And then just recommending ways to control exposures is a really big deal. So allergens, irritants, pollutants that make their asthma worse. So they have to know what made them worse and then how to avoid those triggers and then to look for symptoms and then know what to do. So really having that asthma plan. So here, looking at 0 to 4, 5 to 11, and then adults greater than 12. Here we have our step up in controller medication. So let's look at the adult category here. It says SABA as needed, that's your albuterol. And then here, remember with asthma, all those inflammatory cells are a big deal of its pathophysiology. So that's where you would do a low dose inhaled corticosteroids right away. And then also chromalin sodium. And then the LTR is like your leukotriene modifiers. So that is looking at and preventing those chemical mediators causing more inflammation. So that could be your monoleucast or your Singulair, something like that. So it's another controller medication. Then you go up to the low dose inhaled corticosteroids plus your LABA or a higher dose of steroids. Just remember to don't ever do a LABA in asthma. Don't ever do a LABA alone. So don't ever do like a Severity without the steroid. So you'd want to do Advair over Severity. And then continuing up, high dose steroid plus your LABA and considering some other alternative therapies as well. And really trying to get these patients under control. Something else, though, with asthma is if patients are consistently under control, you can step down. So if they go from, say, your moderate persistent and then they go down to mild persistent, then you can back off on some of the medications with asthma. Okay, so now we're just going to focus on questions. So we have a patient's spirometry shows an obstructive pattern with decreased expiratory flow rates. What recommendation does the RT suggest for further testing? Does anybody have any idea? Patient spirometry shows obstructive pattern with decreased expiratory flow rates. What would be the respiratory therapist's next suggestion? How about another test? Can anybody think of something else you might want to do?
Body box?
Okay, good. So no, not for this one. Good suggestion. So somebody said body box. So not quite yet. For this patient, since you're looking at an obstructive pattern, you would just recommend a pre and post. Yeah, just a pre and post. Yeah. So what you would do then is if they showed obstructive pattern, give them a short-acting bronchodilator and then doing it again, doing the spirometry over and seeing if they have reversibility. Okay, next we have a patient's spirometry shows a restrictive pattern with decreased expiratory flow rates and a normal ratio. Now, what recommendation does the RT suggest for further testing? What was said earlier? So this one, so for restriction, to really see what's going on, this is where the body box. So now looking at lung volumes and capacities and diffusion capacity would all be indicated. Okay, so obstructive, think, okay, are they reversible? So do a bronchodilator. So do a post bronchodilator. Restriction, think about doing lung volumes and capacities. Okay, a patient's pulmonary function test shows a normal DLCO and an increase in functional residual capacity. What disease process is this patient probably diagnosed with?
Chronic bronchitis.
Excellent. Why did you say that?
Because that's the difference between emphysema and bronchitis.
Good.
In emphysema, DLCO is reduced and bronchitis is normal.
Excellent. Very good. Okay. PFT results on a 5-foot tall, 53-year-old female. FVC is 70% of predicted. FEV1 is 65% of predicted. The FEV1 ratio is 88% of predicted. The TLC is 68% of predicted. DLCO is 25 mils per minute, millimeters of mercury. What type of disorder do these values reflect? Obstruction or restriction?
Restriction.
Restriction, good. And that's because we have low FVC and FEV1, but our ratio is normal. It's greater than 70%. And then our lung volume is decreased. Very good.
Hey, Jamie.
Yeah.
Real quick on something like this, how would you tell if the patient has poor effort?
Well, there would have to be something to tell you that. So if you just had these values and this is all you got, this is perfectly showing you because you did spirometry and you did the body box. So this is probably pretty accurate. So poor effort would you'd have to have something in there telling you. So if they said, if everything was really significantly reduced, and if you looked at that peak flow and it was really low also, but as I said, you'd have to have something to tell you that there was a chance for poor effort. Does that make sense?
Yes.
Okay, this is just, once again, don't overthink these questions. This is what you're presented with. And so, this is what you have. Question. To determine the need for ventilatory support in a patient with Guillain-Barré syndrome, which of the following clinical information should be obtained?
C, MIP and vital capacity.
Yes, MIP and vital capacity are the two things that we'll talk to you about muscle strength. Okay, good. We have a 70-year-old male who had smoked for 20 years but recently quit. They now complain of shortness of breath with exertion. Breath sounds are clear but diminished bilaterally. During the evaluation for entry to a pulmonary rehab program, the following results are obtained after a 6-minute walk test while breathing room air. We have 140 meters walked. The patient stopped twice. Their their baseline, their SpO2 on room air was 85%. Baseline, they were 92%. What would you recommend? Initiating oxygen with activity, scheduling cardiopulmonary, administering sorry, you guys, my screen, this is blocked off, so you guys can read this. But which one of these sounds the most reasonable? A, very good. Initiating oxygen with activity. So that at baseline, their heart rate was 98 and 92, and SpO2 92 at the end of the test. And they had to stop twice. Heart rate jumped up to 120 and have 85% SATs. Good. Question. A patient's residual volume is to be measured. What 3 methods could be used to accomplish this?
Body box.
Good. Body box?
Washout,
Nitrogen washout? Helium dilution. Excellent. Okay, results of a pulmonary function study on a patient report. A vital capacity of 3,600 mils, a functional residual capacity of 6,000 mils, and an ERV of 1,000 mils. What is the total lung capacity? So this one's a little bit tricky. So if you know what makes up total lung capacity, yeah, it's vital capacity plus RV, residual volume. Well, they don't give you RV, so you have to go functional residual capacity minus ERV, which will give you your RV. So 6,000 minus 1,000 is 5,000 plus 3,600 is 8,600. Does that make sense?
Yes.
Excellent. Okay, volume per time is the definition of compliance, flow rate, resistance, or elastance.
Rate.
B, flow rate. Good, good. A patient has a TLC, total lung capacity, of 110% of predicted. Okay, right there, you should already say, oh, I've got big lungs, right? Okay, an RV over TLC ratio of 80%. Holy cow, that's terrible. Because what should be the RV over TLC ratio? Only about 25%, right? So what is this consistent with?
Obstructive lung disease.
Good, obstructive lung disease, good. Okay, the DLCO, diffusion capacity, measures ventilation, closing capacity, parenchyma, miscibility exchange gases, or total lung capacity.
C.
C, very good, good, good. Okay, in a patient with post-op atelectasis, PEP therapy is likely to increase arterial carbon dioxide tension, increase functional residual capacity, decrease airway resistance, or decreased VQ mismatching.
B.
B, increase functional residual capacity. Good. A respiratory therapist observes the following patient ventilator graphic. The therapist should conclude that, what do you guys think is happening right here? Is exhalation coming back to baseline?
No.
Nope. So the therapist should conclude that
Auto-PEEP is present.
auto-PEEP is present. Excellent. Very good. Okay, the information below was obtained from a pulmonary function report from a 40-year-old male who weighs 73 kilos and is 5'9" tall. FEV1 is 53% of predicted. FVC is 55% of predicted. FEV1 over FVC is 90% of predicted. And his DLCO is only 51% of predicted. There is no response to bronchodilator therapy. Which of the following should a respiratory therapist recommend next?
Bronch.
I think schedule an inhalation challenge.
So when we just look at spirometry of 53%, 55, and 90, is that obstructive or restrictive?
It's restricted. You want to do A.
Good, good. So it would be A. So you'd want to obtain your lung volume measurements as well. A 57-year-old male admitted to the hospital complaining of dyspnea on exertion and a dry, non-productive cough. Before we even go further, we can probably already think about what that is, but we're going to keep going. Okay. Reports the symptoms have been worsening for the past 2 months. The patient's respiratory rate is 28 with fine inspiratory crackles throughout the lung fields, but most prominent over the lower lung fields. Spirometry shows a restrictive disease. Which of the following should a respiratory therapist recommend? So what do you think's going on with this gentleman? He's younger. I mean, he's in the younger range. He's complaining of dyspnea on exertion and dry, non-productive cough. Fine inspiratory crackles. Restrictive defect. So what would you guys recommend and why?
I want to say CT.
And I want to say you're correct. Why did you think that, Zenon?
BQ perfusion studies kind of crazy. He
that's
already has a respiratory rate of 28, so exercise doesn't seem right. And then
Right.
inhalation challenge, same as C.
Right. So inhalation challenge is indicated for somebody suspecting of asthma, right? So CT scan of this chest is indicated because this patient probably has an interstitial lung disease. So you'd probably expect to see some of the diffuse honeycombing on both sides. You're right. VQ study is looking at pulmonary embolism, perhaps, exercise stress testing for somebody with perhaps a cardiac issue. And then inhalation challenge, as we said, is asthma. Very good. Okay, we have a physician orders smoking cessation counseling for a 60-year-old male newly diagnosed with COPD. At the 1-month follow-up visit, the following ABG analysis results are obtained: 738, 45, 56, 27, and 1. Hemoglobin 16, SiO2 measured of 82%, carboxyhemoglobin at 5.5%, and a met hemoglobin at 1%. Regarding the success of the smoking cessation counseling, a respiratory therapist should conclude the results reflect no smoking, reflect smoking, are inconclusive, or reflect inaccurate.
Reflect smoking?
Is it
Yeah.
B? Yeah.
Yeah, B as in boy. Reflect smoking or environmental exposure. Our carbon monoxide should only be like 2% max. Okay, so anything over 5% shows that there's some smoking or environmental exposure. Good. Okay, respiratory. Okay, Zenon, this was, you asked me about assisting in a procedure last week, so I threw this one in just to show you an example of being tested on assisting with a physician. So it says a respiratory therapist that is assisting a physician with endotracheal intubation. Which of the following should be used initially to confirm tracheal intubation? So what do you guys think? Initially.
Marking or G.
B as in boy.
Okay, no. So the first thing you guys think about, the doctor puts in, and what is the first thing you guys do? What do you put on?
Capnography.
Capnography.
Yeah,
Ontopy.
throw on your easy cap and then you start bag valve masking, right? Or start ventilating with the ambu bag. Good. So the answer is D as in dog, colorimetric capnography. That just means your easy cap. Do you guys see how they can use complicated terms to think? So it'll throw you off thinking, oh my goodness, what is that? But it's just using your easy cap.
Okay, so Jamie, real quick on this one.
Sure.
I had a very, very similar question,
Mhm.
but one of the choices was, so there was condensation in the tube. I think instead of pulse ox, there was observed chest rise.
Right.
And I was like really torn between
Yeah.
capnography and chest rise.
Yeah. Well, the thing is, generally, you put that easy cap on before you even bag.
Yeah, that's true.
Yeah. So, I mean, chest rise is always good too because it's observable, right? But you would always put that, if you kind of can think about the steps. I know it's been a while since you've been in there, but you could put that easy cap on before you would even bag.
Okay.
Yeah. But once again, they'll ask things in different ways. So make sure that you make the best choice for that specific question, right? It's always the best answers. Okay, which of the following indicates a physical conditioning program has been effective for a patient with COPD after 2 months of therapy? Resting pulse rate is unchanged. The 6-minute walk distance is increased by 60 meters. The vital capacity is increased by 5%, or the FEV1 has improved by 10%. So we're going to, what?
It's B, the 6-minute one.
You're absolutely correct. It's B as in boy. The 6-minute walk distance is increased by 60 meters. And I think that one's a hard one. So you did a really good job, but just read what that says. So physical conditioning, we can only measure that with the 6-minute walk test. So very good. Okay.
Yeah, I had, sorry. No, I had a similar question in Oaks Academy when I was doing some quizzes.
Oh, yes. Yeah.
I checked pulmonary rehab. You have to check 6-minute one.
Yep, exactly right. Listen, myself, Oaks, Kettering, there's only so many questions out there. So the more studying you're going to get, you're going to see the same ones repeated. You're going to go, oh, after a while, you're going to, I'll get A's on these credentialing exams. But at least get higher, just pass. That's all I care about. Question. Which of the following values is used to evaluate an individual's response to inhaled bronchodilators? The response.
FEV1.
FEV1, absolutely. We need a 12% response in FEV1. Very good. Okay, quality control must be performed for blood gas analyzers every. I would have no idea, but I might, because I used to work in a hospital. I know we had to do these, or the lab techs came and did this, but the answer here is 8 hours. And the CLIA, which is the Clinical Lab Improvement Amendments of 1988 Act, they're the ones that dictate and look at quality control for ABG machines and point of care. So in point of care testing, so like your rapid points or your those the stat ones that you run in the ED. So that's, if you want to, you can go to the website and look up more stuff. But I mean, I wouldn't. There's 3 questions total between spirometry and CapNog and ABG quality control. So this one comes up, I think, on every exam or something close to it. So every 8 hours is what they recommend. Which of the following indicates auto PEEP in a patient receiving mechanical ventilation? Expiratory volumes are lower than the inspiratory volume. Expiratory flow does not return to 0 before the next mandatory breath. The pressure time graph is concave and the flow curve is constant, or the pressure volume loop shows a duck-billed appearance. This one's a good one. What do you guys think?
B.
Yep, absolutely. B as in boy, expiratory flow does not return to 0. So if we had expiratory volumes are lower than inspiratory volumes, that indicates a leak in the system. If the pressure time graph is concave and the flow curve is constant, that's if it's concave, probably inspiratory flow is probably not adequate. The pressure volume loop shows duck-billed appearance. That shows overdistension in the lungs. So yeah, this was a good one. When instructing a patient on the administration of salmeterol, which is Severity, which of the following is most important to emphasize? Gargle immediately after use, inhale slowly with the breath hold, breathe in fast and deep, or shake medication vigorously before use?
It is C, breathe in fast and deep, because you use DPI to.
Yes, exactly. So you use a DPI and that needs a good inspiratory force. Okay, so breathe in fast and deep. So very good. A patient with severe COPD continues to complain of dyspnea on a home regimen that includes tiotropium bromide or Spiriva and albuterol. A respiratory therapist should recommend adding What do you guys think? So they're not being controlled, and they're on a LAMA and a SABA. And what else could you recommend adding in? Would you recommend a inhaled corticosteroid and a LABA? A montelukast, which will help with inflammation. What's acetylcysteine?
Mucolytic.
Yes, a mucolytic. And so
Mucomist.
medicine. Okay, so no. So what do you guys think it is?
I think it should be A.
It is. It is. A, fluticasone or salmeterol. Okay, very good. Which of the following is the best monitor of bronchodilator therapy effectiveness for a patient with asthma? Subjective improvement in dyspnea, arterial blood gas, peak flow, or chest radiograph? Asthma.
C.
Good. C.
Peak flow.
Measurements. Yep. Yep.
Yeah.
Yep. C. Peak flow measurements. Great. Good. 35-year-old patient with asthma is being evaluated 1 week after discharge for an acute exacerbation. The patient's home regimen is albuterol MDI, 2 puffs, QID 4 times a day. The patient continues to have wheezing throughout the day. A respiratory therapist should recommend Zopanex, Singulair, Flovent, or Zithromax.
Singular.
So what do we do in zone 2? So when we have a SABA and that doesn't work, what do we go up to?
C.
Yep. Yep. An inhaled corticosteroid. Good. "32-year-old non-smoker presents with persistent shortness of breath. The following spirometry data are obtained, pre and post bronchodilator." Okay. So FEV1 pre-bronchodilator is 3.8. Post bronchodilator is 4.6. So, and then the other results you can see here. So we should look at that FEV1, and to see if it's worked, we would say 4.6 minus 3.8 equals 0.8. Okay, so that difference divided by the original, so 0.8 divided by 3.8 is 0.21, or a 21% change. So a respiratory therapist should next recommend what?
A.
Yeah.
Initiating broncho.
Yeah, initiating inhaled bronchodilator therapy. Very good, because post bronchodilator showed that it was effective. So this person is reversible. Good. The following data are obtained for a patient. FEC 5.79, RV of 2.46, FRC 4.3, ERV 1.84, and IC of 3.95. What is the patient's total lung capacity? So what are some of the, what could you add together? Think of your mnemonic.
Vital capacity and residual volume.
Yes, that could be one. So vital capacity and RV. What's another one you could have done? But you're right, Zenon, that was correct.
FRC and IC.
Yep, FRC and IC. Good. So if you add those together, it's 8.25 liters. Okay, which of the following should a respiratory therapist instruct a patient to use when cleaning home CPAP mask and connecting tubing?
A. Acidic.
Okay, so I was a little bit confused, but NBRC said on this one that dishwashing soap was appropriate, was the one that was indicated. And I put this on here because when they talked about home nebulizers, they were talking about acetic acid, so vinegar. But for this one, home CPAP mask and connecting tubing, they said dishwashing soap. Okay, so it just kind of depends on which one you're looking at. So for the home CPAP, I would choose dishwashing soap. During a bedside interview of a patient with COPD, a respiratory therapist asks the patient how he handles the limitations to his daily activities. The therapist is most likely assessing the patient's
It's A, emotional state.
emotional state, A. Good. Okay, so that's it. So I just put my references here. I'm going to stop sharing. Uh-oh. Okay, stop recording.